Okay, so this is Annie Holmes from Strive, and welcome to today's webinar, today's Learning Lab. I'm going to hand over to Sinead Delaney-Moretwa from Wits RHI, who's going to host and lead the webinar and introduce our presenter. Thanks so much.
Thanks very much, Annie, and good afternoon to everyone from Johannesburg. I'm delighted to be able to introduce Dr. Audrey Pettifor. Audrey is a long-standing friend and colleague who did spend some of her early years at Wits RHI, but is currently an associate professor within the Department of Epidemiology at the University of North Carolina in the U.S. And this afternoon, she's going to unpack the results of the HPTN 068 trial, which was a randomized controlled trial of cash transfers conditioned on school attendance amongst adolescent girls and young women to look at the impact on HIV incidence. Looking forward to hearing the presentation. Wits RHI, who is a Strive affiliate, has been a partner in the project, and there are a number of collaborations that have been linked to Strive. So it's a great opportunity for Strive and Strive partners to learn more about the trial. For those of you who are not familiar with Strive, Strive is a research program consortium funded by research that is led by the London School of Hygiene and Tropical Medicine and includes partners in Africa and India. So in Africa, Wits RHI and the Rwanda Intervention Trials Unit in Tanzania, as well as ICRW in the US and India, and Swa-Koteka Health Promotion Trust in India as well. And Strive focuses on topics that are aimed at understanding and addressing the structural drivers of HIV. With that introduction, I'm going to hand over to you, Audrey, to tell us more about 068 and what you've come to understand about the results of the trial.
Thank you. Good morning, everybody. It's still early here in Chapel Hill, so the joys of webinars. It's a pleasure to speak with you this morning. So for those of you that perhaps haven't seen the results, today I'm going to give you a little bit of background to tell you sort of why we did the trial, and then present the main results of the study, and then talk to you a little bit about sort of some of our interpretations, and would love people's thoughts and questions also that you may have as a result of, thoughts from seeing these results of your interpretations. What started this study back in 2002 when I was at Wits RHI, which was then RHRU, we conducted a nationally representative household survey of 15 to 24-year-olds as part of a larger evaluation of a youth program. And this was back when people weren't doing a lot of HIV testing other than through ANC clinics, through sentinel surveillance. But the DHS had just started to add HIV testing as part of its program, and we started to see this same pattern that young women were, 2 to 3 times more likely to be infected compared to young men the same age as themselves. And perhaps more strikingly, we saw this rapid takeoff in infection. So that about 4% of 15, 16-year-olds were infected, but by the time young women reached their early 20s, a quarter to a third were infected. And so I've spent sort of the last 11 years or so that I've been back in the States at the University of North Carolina trying to better understand sort of, what was going on in South Africa that was leading to this rapid takeoff. And I think obviously Strive, you guys know this well, but I think what we started to see and what I think has been increasingly recognized when trying to understand why young women are at such high risk are some of these really important structural drivers such as poverty, education, lack of gender power, inequality, gender-based violence. And education is certainly something that consistently came out in our work as being either a risk factor or protective. So we saw that young women who had not completed high school were almost 4 times more likely to be infected with HIV compared to young women who had completed high school. And this was, again, in this nationally representative survey in South Africa. So this has been sort of confirmed, as you know. James Hargreaves, who's part of your group, has did a nice review in 2008, and I think we've continued to see consistent evidence suggesting that more education is protective for young women. And so I think that, led us to be thinking about what are barriers to schooling, and certainly throughout sub-Saharan Africa and certainly in South Africa, financial barriers have been cited as one of the major reasons why young people and young women in particular don't complete school so that they can't afford the school fees, or uniforms certainly have been cited in a lot of our formative work as a major barrier. And then also young women are obviously more likely to be taken out of school, either to support the family or to care for sick family members or to take care of small children. And young people, in particular young women, make up sort of one of the largest groups of unemployed persons globally. So and this can be a driver of young women engaging in things such as transactional sex or sex work. So we started thinking about, okay, what could we do to keep young women in school? And cash transfers have a long history in the development field of being successful at getting young people to go to school, in particular young women. This is a nice review that Sarah Baird completed in 2013. And of 35 evaluations that have been done globally of cash transfer programs, I think there's really strong evidence showing that they can increase enrollment. Both conditional and unconditional transfers can increase school enrollment, especially secondary school enrollment. And in particularly, we see, again, stronger results for girls compared to boys. This is just to say, so that got us thinking about cash transfers, and actually in 2012 we did a review of the literature thinking about cash and seeing what was out there in terms of cash as a prevention, specifically to prevent HIV, not thinking about sort of adherence or other outcomes for HIV. And really we kind of grouped the programs that were out there into two categories. So what I call kind of upstream approaches, which I think is sort of the traditional social protection approach where you're providing cash to poor families. It's really, a safety net, a poverty alleviation mechanism, and that will trickle down and reduce HIV risk by, addressing these sort of structural barriers such as poverty and education. And then I think we've seen a proliferation, especially of these what I call downstream approaches, which are more like contingency management from psychology, where, you're really providing cash as an incentive for a particular behavior change. So money to test for HIV or to take your ART or for male circumcision. In particular, some of the examples that the World Bank has done, such as cash for negative STI tests. And at the time in 2012, there were over 16 studies that had been completed or were underway. And we kind of asked the question of whether both of these approaches would work the same in different populations and sort of what the implication is for scale up and actual, delivery at a country level, in particular some of the downstream approaches. So I think many people may be aware of the Zamba Malawi trial. So this study was a large randomized control trial of 3 arms, a conditional and unconditional and a control arm. And it was a complicated design, but essentially there was money provided to young women and money provided to their parent guardian, and the amounts varied. In the end, they didn't have power to look at the 3 different arms of the trial, but at 18 months, they basically saw that girls getting cash payments, both conditional and unconditional, were less likely to be infected with HIV, and pretty big effect estimate. And they also saw that these young women were less likely to report sex in the past week and to have a partner who was greater than 25 years of age. So they really their conclusion was that the cash kind of helped change partner dynamics. It's that young women were able to choose safer partners, and this reduced their risk. Okay, and then we have examples, like I said, of sort of the Lesotho trial that the World Bank has done, where men and women are randomized to different lottery arms, so a high lottery and a low lottery, which is conditioned on a negative STI test that was conducted every 4 months. And this is also so this trial did have incidence. It's actually one of the only trials other than 068 to date that's had an incidence marker. And they saw that those people who were eligible for the lottery had a lower incidence of HIV, especially among women, and for the group that was able to sort of win the highest prize lottery. So I think kind of proof of concept, these are the bank trials kind of showing that cash has this sort of traction that it can potentially reduce HIV infection. And again, I guess just the last piece of evidence that kind of has come prior to the 068 trial was some observational studies. This is work by Lucy Kluver looking at the Child Support Grant in South Africa, which is a large poverty alleviation grant provided to poor homes. So for every child in the home in South Africa up to the age of 18, up to 330 rand, which is sort of $30-ish, the exchange rate keeps fluctuating, is provided every month for every child in the home. And she saw that the homes getting this grant were less, those adolescents were less likely to report age-disparate sex and to report having engaged in transactional sex. So there's some pretty good observational self-reported data. I think that's where most of our evidence to date has been, showing that cash seems to potentially have reductions in HIV, and then obviously the Zamba and the bank trials showing some outcomes on biomarkers. So we kind of were trying to think about, okay, so there's evidence to show that cash can keep girls in school, and we knew that schooling reduced risk, so we started thinking about this. So here we have cash on the left, and the idea is that the cash could either keep girls in school, which could reduce their risk of HIV. It might help them have a greater hope for the future, which might also help them, engage in safer behaviors and reduce risk. And then the other mechanism, so I think the two big mechanisms are schooling, and the second one people talk about is that it can reduce dependence on male partners, reduce engagement in transactional sex. In this trial, so the next study, I know this is a busy slide, but the primary mechanism that we, again, were trying to look at was school attendance. So we really wanted to keep girls in school to reduce their risk. And these are just various mechanisms and things that we've tried to measure in the study. So kind of home and parent level factors that might be affected by the cash transfer, peer and partner level factors, and schooling factors, and obviously individual level factors. So I'll let you kind of digest that at another time, but we did try to measure all of these mechanisms. So now, post 068, we can start trying to look at some of these things to try and understand the results and understand the impact of schooling on young people. So now, 068. So 068 was a phase 3 individually randomized trial, and I think the individual piece is going to be important in thinking about the results. Zamba was a cluster randomized trial. Our primary endpoint was HIV incidence, and young women and their parent guardian were seen at baseline, and then we saw them annually for up to 3 follow-up visits between March of 2012 and the last participant was seen in March of 2015. So we finished the data collection quite recently. And the intervention was a cash transfer, which was provided to young women and their parent guardian conditional on 80% or greater school attendance every month. So we collected attendance rosters from the 27 high schools in our study area, and we then looked to see whether, by looking through the attendance roster, was the young woman there for 80% or more of the days, and if she was, then we made a cash payment into an account that she had opened, so a direct wire transfer into an account for the young woman, and then also the parent guardian had to have an account, and also a transfer was made to the parent guardian. So it was split like a third for the young woman, 2/3 for the parent guardian, and the amount, again, was benchmarked. We benchmarked it to the amount that the child support grant pays, so that hopefully this could have policy relevance if depending on the outcome. So we measured HIV and HSV2 at every visit, and we did an interview with audio-computer-assisted self-interviews where we collected a lot of information on sexual behavior, schooling, intimate partner violence, mental health, alcohol and drug use, and a number of other things. And we also interviewed the parent guardian at each of these visits, which is a very detailed assessment of socioeconomic status, kind of measuring consumption, like food consumption and household consumption, as well as sort of intake of grants and a lot of detailed SES information. And we also have a very large qualitative component to the study, which Catherine McPhail, who was at WRHI, led, and Nomse Kosa, who's at Wits RHI as well. They led that component to the study, and I'm not going to present that data today, but we have a wealth of qualitative information, which I think will help us in understanding some of the results. So this study was done in the Agincourt Health and Socio-Demographic Surveillance Site. Is up near in the northeastern part of South Africa and in Mpumalanga province. It's near the Mozambican border, so there are a large number of former Mozambican refugees in this area. And it's 28 villages consisting of about over 100,000 people. The HIV prevalence in this area is very high. In 2012, when they measured it, it was around 45% among those 35 to 39 years of age. And this area is also known for having high poverty levels. It's a former homeland under the apartheid government. So there's just not a lot of resources or job availability. So there's a lot of migration, circular migration for work. About 50% of men migrate for work, and increasingly women as well. So these are the eligibility criteria. So at baseline, obviously they had to be a female, and they had to be enrolled in high school. And so this was grades 8, 9, 10, or 11 in the 27 high schools in the study area. These were all government schools. And they had to be between the ages of 13 and 20, not married or pregnant by self-report at baseline, have a parent guardian living in their home, and be able to complete the computer survey, so being able to read and be able to reside in the study area. These are the baseline results. So we enrolled over 2,500 young women in the study, and 2,448 were uninfected at baseline. And you can sort of see some of the characteristics. So, again, these are young women. They were in high school. The median age was 15, so they're young, and thus only about a quarter reported ever having had sex at baseline. HIV prevalence was about 3%, and genital herpes 4%. 9%, interestingly, even though they're in school, had already had a child. And although we required the parent guardian requirement because it was a research study, almost 30% were either a single or double orphan, and close to a third reported food insecurity in the past year. And you'll also see as a marker of poverty, about 80% of the homes were already receiving the government's child support grant. So high coverage of social protection, and that's going to be an important takeaway at the end. So just a little bit on the study. Retention was good in the study. It was 91% over the 3 years. There was a difference between the control and the intervention arm, but in analyses we've done sort of adjusting for that, it hasn't made a difference to the results. Also, in terms of payment, like almost 100% of all of the intervention girls actually received the cash transfer during the study, so high uptake of the intervention, if you will. And as this was done through the HPTN, it was sort of conducted as you would conduct a drug trial. So there was a data safety monitoring board which met 4 times during the study, and there was quarterly external clinical trial monitoring of the trial during the study. So one of the things people were really worried about, because we were providing cash to minors, in particular young women, were social harms. So we had pretty intensive monitoring of social harms. But during the trial, there were only 16 reports. There were 9 in the intervention arm and 7 in the control arm. And these, about 81% of them were due to reports of teasing and jealousy related to being in the study. So we had nothing specific to receiving cash. Again, these were sort of things related to being in the study, and in general, young women did not report them. It wasn't something that they were concerned or wanted help with. They just sort of said that they had friends who had teased them for being in the trial. Okay, so the main result, there was no difference. We did not see an impact of the cash transfer on HIV incidence. So the hazard ratio was 1.17, and the confidence interval was 0.8 to 1.72. I do want to point out, because in the wake of this study, I've heard different interpretations of the trial, and I've heard some people say, they didn't have power to look at incidence, or if the incidence was higher, we would have been able to see a different result, and that is not the case with this study. So we have enough power to answer the question. And as you can see, because the hazard ratio is almost 1, and if anything, it's tilted towards above 1, right? If the cash transfer were protective, it would be below 1, but it's above 1. So in this case, even if we'd had a higher incidence, the effect size doesn't suggest that we would probably see a different result. So power is not one of the issues at play in this trial. There were 107 incident infections, and you can see there were 59 in the intervention arm and 48 in the control arm. And overall incidence in the trial was 1.8%. So lower than we thought. And again, I think this goes back to will be one of the conclusions, is that school-age girls in general, I think are not at super high risk, at least in this area. So I guess the surprising result, and the thing that we've kind of been trying to grapple with, is the school attendance result. So there was no significant difference in school attendance or permanent dropout by study arm. So I showed you at the beginning, right? Like 30 plus studies showing that cash transfers increase school attendance. And so this was really surprising. We did not see that the cash was increased school attendance, or at least the control arm attended as much as the intervention arm, and attendance was incredibly high. So 95% of girls in both arms were in school throughout the trial. So this is attending school 95% of the time. And dropout was low at around just under 3%. So really high attendance. And we'll talk about that. This is a new result. So we didn't present HSV2 at the IAS conference, but there was no difference in the incidence of genital herpes. It is in the right direction, at least. So here the relative risk is below 1, so 0.92, but not a statistically significant result. Okay, so then moving to sexual behavior, we did see that there were some significant differences in behavior. And actually, if you look at the relative risks, 1, 2, 3, the fourth column, you'll see that all of the relative risks are under 1. So, suggesting that the transfer was potentially protective, but we only see that 3 of these behaviors we reach statistical significance. So girls in the intervention arm were significantly less likely to report having had a sex partner in the past 12 months, 32% versus 35% in the control arm. They were significantly less likely to report any unprotected sex in the past 3 months. And I think the strongest result we've seen, and actually I think it's somewhat surprising, is the intimate partner violence. So girls in the intervention arm, 22.7% reported IPV at any visit compared to 31% in the control. So almost a 10% difference in intimate partner violence. And I think this is particularly interesting given some of the concerns that were raised at the beginning about, providing cash, particularly cash to young women, might increase their risk of violence. I can tell you that this result is actually being driven by a reduction in physical violence. So it really seems like the girls getting the cash experience less physical violence rather than sexual violence, which was not, the majority of them were actually experiencing physical violence rather than sexual violence. No difference in coital debut, partner age, transactional sex, or pregnancy, although they are both coital debut and partner age differences. Those are, the differences are relative, about 3%. 2% to 3%. This is just some data so you can see what the actual incidence. So while incidence was 1.8%, I think in terms of thinking about next steps, again, this idea that, the majority of girls are in school roughly up to about 18. And then obviously in the South African context, there's a lot of grade repetition. And so you do see girls in school past the age of 18. The numbers were smaller in the trial, but you can see that incidence was less than 2% and very low for the 15 and unders, and then kind of under 2% all the way up to the age of 18. And then at 19, we see this jump. And really, once you get above 19, we see incidence greater than 3% and close to 5% in the 20 and 21 and older. So I think this idea, and the UNAIDS has talked about with PrEP and targeting of, wanting to target those with incidence greater than 3%. Again, this is sort of general population, although they were in school. We really see the quote-unquote low-risk girls, experiencing high incidence once they reach the age of 19 in our trial. So one of the bright spots, in addition to the intimate partner violence and reduction in risk behavior, was that we did see, as we hypothesized originally, that schooling was protective. So although school dropout was low, we did see that for girls that dropped out of school, they were significantly more likely to acquire HIV. So the hazard ratio was 3.2, so 3 times more likely to acquire HIV after dropping out of school. So this was, again, longitudinal. So we kind of looked and saw the infection did occur after they had dropped out of school. And the same thing with school attendance. So girls not attending, greater than 80% of the time also had a hazard of 3. Sort of 3 times the risk of acquiring HIV if they weren't attending school regularly. Just so you can kind of see what young women were spending and households were spending the money on. This was over the duration of the trial. We haven't looked at it yet kind of by year. But I think, interestingly, you'll see that the top things that the guardians were reporting spending money on were food for the household, other household items, school fees, school uniforms, school supplies. So those are all above 10%. And then things like clothes and shoes and toiletries and soap come in just at around 10%. If we look at the young women, on the other hand, the top thing they said they spent the money on were toiletries, followed by shoes and clothes, school uniforms and supplies, cell phone airtime, hairdressing, and makeup at 20% and higher. So really these things that young women talk about needing and wanting. And interestingly, from the qualitative data, it seems like that's certainly something that is talked about as an impact of this cash, that girls, it sort of reduced tension in the home because they weren't sort of squabbling with their parents about pocket money and, wanting money to buy these things that adolescents, need and want to feel good and fit in and kind of be part of the team. I think some of the work that Meghna Ranganathan, who's part of Strive, also, she had done some work on transactional sex in this area, suggesting that, the reasons why young women engage in those behaviors are to acquire some of these things that kind of improve their self-esteem and make them feel like they fit in. Yeah, so just in summary, again, we didn't see that the cash transfer reduced HIV and new incident infections, but we did see that girls getting the cash reported fewer sex partners, less unprotected sex, and experienced less IPV. Surprisingly, school attendance was high in both arms, and staying in school and greater attendance, though, did reduce risk. And overall, risk was low. So I think our interpretation that in general, girls in school, if they're in school, they're at relatively low risk. There is a subgroup at risk, but the majority are not at risk. Okay, so then I have a few slides just trying to unpack some of the results, what we've been thinking about. So one of the questions we get asked is why such high school enrollment, right? Why do we see 95% enrollment, and why did we do a trial somewhere where enrollment was so high? So South Africa is known for having high school enrollment, but certainly not 95% enrollment. And actually, data from the South African Department of Basic Education from actually 2012-2013 shows that enrollment rates in Mpumalanga province, where we did this study, are about 85% for 16 to 18-year-olds. And that's sort of in any educational institution, not just in kind of government secondary schools. But I think the things that are important in this area are that, like I showed you, there was very high social protection coverage. So over 80% of the homes are getting the child support grant. Because this area is so poor, it's exempt. The government of South Africa sort of ranks schools by tertiles, and if you're in the bottom two, you're exempt from school fees. So there's no school fees at the public schools in this area, the government schools. There's also school feeding schemes in many of the schools, and so kids often do go to school just to get food, to be fed. And so I think you have this background level of protection, which is reducing kind of financial barriers to schooling. And then our qualitative data seems to suggest that there are study and peer effects potentially going on. So I do think there's potentially some, you can call it spillover, peer effect, contamination, but this idea that not only did the control arm see intervention girls going to school, their friends going to school, and therefore perhaps had some impetus to go, but that the nudge of the study saying we're studying education, and I think the sense that they felt like the study was conveying that schooling was important, that kind of nudge perhaps was enough to bump them up. So those are some working hypotheses. There's also the potential that just because we originally selected in on school attendance that we somehow selected the higher attenders and the lower attenders were already gone. But I think there's some of that going on, although I do think that we still would have seen less than 95% in general. And when we've looked at data from the Agincourt DSS, and we're trying to do some modeling of that now. But in general, schooling is lower in the households that were not in the study. So obviously we've got to sort of adjust for selection bias there. But I think some questions about study effects and also, about what can happen when you have good social protection coverage. I think one of the challenges is trying to understand some of the behavior outcomes. Again, the vast majority of data that we have on social protection programs and HIV reduction are from self-report. And, I always say, if we had presented this data without the incidence, without the biomarkers, what would the interpretation have been or the take? And I think it's hard when you see these protective effects of behavior, but then there's no impact on the biomarkers. And so, I think that's hard to really know what that means, but we are trying to unpack the IPV results and trying to see both qualitatively and quantitatively sort of, was it things like increased self-esteem, hope for the future, that the cash allowed girls not to choose certain partners? I mean, we do see the fewer sex partners in the past 12 months. And so, did girls stop having kind of these casual, maybe riskier partners that might be more violent? We don't know, and that's something that we are wanting to look at. So I think some of the implications is that I think we can say, at least from this study, that schooling is protective for HIV, which is our original hypothesis. And unfortunately, we can't look at it through the cash transfer mechanism, but through the dropout mechanism, we see that. Again, there's low-risk behavior overall. Only about 30% of girls reported having a partner at any time point during the study, and only about 10% reported engaging in unprotected sex at any point during the study. So I think things to think about in terms of, targeting and programs. Again, those that dropped out, while a small number, were at increased risk. And so I think a question, again, about greater focus on sort of 18 to 24s and out-of-school youth in this immediate sort of push to really get incidence down in young women. I certainly think in places with low school enrollment, cash can probably help increase attendance. And most places in sub-Saharan Africa have much, much lower secondary school enrollment and attendance rates than South Africa. And the bank is actually embarking on another randomized trial with cash transfers in Swaziland and looking at incidence, so where enrollment is much lower. So that trial will be taking place, is my understanding. I think also an idea that's taken traction is the idea of cash plus. It's something that Lucy Kluver has looked at in some of her observational work. We recently completed a pilot test of kind of an empowerment and gender-based violence financial education intervention with girls who had exited the CCT trial. And interestingly, I think there's a big push to really have sort of short, people say that things like stepping stones and other multi-session interventions aren't feasible in these contexts. But interestingly, so we kept our intervention to 4 sessions, and we got resounding feedback that was not enough, that the girls would like more, potentially 10 or more sessions. We had sort of a mentoring and social support, and that came across as something that they really liked and was important, but particularly in a rural area like this where unemployment is high, I mean, I think a real strong sense of having a group, having an identity, having something that they could do and go to. So it's something we're thinking about, and I definitely think, I'm not sure if I'll get to it, but I think something we can talk about is the kind of implications of cash. If cash if keeping girls in school isn't the mechanism that cash is working through, if the mechanism is going to be reducing transactional sex, can we really afford those as programs, particularly in sort of emerging economies like South Africa? I personally don't think that we can provide enough cash to buy out people out of transactional sex. I mean, the things that girls talk about wanting in this context is, while there is some transactional sex being driven by, for example, needing to get food by poverty, I think a lot of it is being driven by consumer desires, wanting to fit in with their peer group, sort of an aspirational goal, and therefore things like Blackberries and designer jeans and designer shoes and, how much money would you actually have to provide to prevent that from happening? So I think thinking about maybe if you combine cash with things like self-esteem building and goals for the future and thinking about, educational and financial training, that might have more sway or more impact, because I'm not sure cash alone in that kind of context will work. And I would love your thoughts on that. But that's kind of my current thoughts. So I think as next steps, obviously, as we keep learning in prevention with young women, I think everybody thought, cash transfers, it's so easy. We can just put cash in people's accounts or give them cash, easy peasy. And again, this trial says, okay, there's really no magic bullet when we're thinking about prevention. I think, obviously, DREAMS and others are moving forward with cash transfers. And I think for those programs, you need to really think hard about the purpose of the cash. As with all structural interventions, as I'm sure you guys have probably talked about before, context is really, really important. I said context, context, context. So what are you trying to achieve with the cash? How do you expect it to work? And really thinking hard about the design of the program. I do think we need to think about targeting. I think from cash transfers that have worked, targeting seems to be really important. So who will benefit most, who gets the money, I think thinking about those things is important. I think also thinking about focusing on the out-of-school and 18 to 24s is important, at least for the time being. And then it raises these questions of how long are you going to provide this money for? I think other important questions are about how to package, again, the cash with care or other prevention services, how the cash fits into combination prevention, and are there other forms of economic strengthening that we should be looking at besides cash transfers? Okay, so I'll stop there, and I want to thank everybody who was part of this study, in particular my co-PIs, Kathleen Kahn from the MRC Wits Agincourt Unit and Catherine McPhail from WRHI, University of New England, and Xavier Gomez-Olive, who is the study investigator of record, and then lots of people at UNC, at MRC Wits, at WRHI, and then at the HPTN who helped make this study possible. So thank you. I'll stop there and take questions.
There is already one question from Kirsten at ICRW. She'd love to hear more about your thoughts.
The Zamba and differences in the contextual factors. And where cash transfers might have a larger impact. Okay. I do think thinking about, the Zamba trial, right, saw really big effects, and they gave girls like $1. So I would love to hear from the South Africans on the line, but, 10 Rand or even 13 Rand in South Africa, can barely buy you a Coke. So the thought that is going to have huge impacts somewhere, like South Africa, I think is really challenging. So I do think in very poverty-stricken, poor areas, a small amount of cash can make big differences. I will say that I think one of the things to think about is that, in the Zamba trial, which was quite short, it was like a year that they did it, when they've gone back and done the post-durability of effect analysis, although they haven't looked at the HIV results, they haven't been sustained. And so I think one of their conclusions from that, it was a 3IE report that they just released this year, kind of saying that perhaps they didn't build enough social capital really in that short intervention to really see sustainable results. So I think it's something to think about. But yes, I think cash transfers for schooling in an area where girls don't go to secondary school at all, and thinking about using it as a, transition point between primary and secondary, potentially you'll see much greater effects. I also think it's difficult when we're doing randomized trials. I think you do suffer sometimes the effects of research, right? So if you were doing more of an implementation science, operations research, I think that there is a very big evidence base that cash transfers can help kids go to school. So I think that is true. And I guess in terms of transactional sex, I think, maybe in poorer areas like Malawi or other sort of more poorer places than South Africa might see bigger impacts of smaller transfers. But in contexts like South Africa, I do think thinking about combining it with other things is probably going to be really important.
Another comment now from James Hargreaves.
Have you looked at whether reported partner age was associated with incidence? So, yes, we submitted. We're going to have a poster at CROI. So this is like probably embargoed information. But so actually we looked at mainly the secondary outcomes that I presented here from this trial, and I will say that the two things that were very strongly associated with incidence in the cohort were having a partner 5 or more years older and engaging in transactional sex. And those two things, the relative risk was like over 3. So strong effect estimates for those two. We didn't see super strong associations with some of the other things like unprotected sex and, partner numbers. So yes, we do see that. And I guess one of my interpretations, again, is in a setting where the majority of young women are at low risk and you see low incidence, that, this is when incidence is taking off in this like birth cohort, age cohort, if you will. And I do think that, it's kind of the early signals that the high risk kids are getting infected. And I think as they start to age, perhaps some of those high-risk behaviors will taper off, and that, you don't see things like from the Africa Center and I think the boys cohort that has not seen partner age being associated with incidents. I think maybe those things will wash out as the cohort ages, but that's just a working hypothesis. And then you said, can we assume your figures for dropout and low enrollment and the association with HIV are adjusted for age? For schooling, it does, the hazard ratio does go down. It actually was not adjusted for age originally, but it still remains a strong association. It's not as strong once adjusted for age, but it's still there. I think it's close to 2 as opposed to 3 when adjusted for age. And you said, overall, to me, it feels like the key thing remains that being in school is protective. I agree. Probably at last because of an effect on partner characteristics. So people can't stay in school forever, and the big question remains, what can schools do to prepare young women better to protect themselves after they leave school? I agree. I agree. And I think the challenge with scarce resources is balancing between the girls who are already out. Like, I think that there is a lot of low, if you want to say, like, an opportunity for prevention in the sense there are young women right now who are out of school, leaving school, have dropped out and are not HIV infected right now and are probably going to become infected in the next year or two. And there aren't services. We're not capturing them. So to me, it feels like that's like a priority to prevent infections. And then, like from the upstream perspective, I think we do need to be working in schools and trying to prevent, the larger group from entering that cohort. But I do think there's a lot of at-risk young women right now who are not getting the services they need that are kind of, to me, like an ultimate priority. But I agree, James. Okay. And then I see David Ross. Hi, David. If the mechanisms whereby cash transfers have an effect is keeping girls in school and attending school, then the intervention had no chance to show this. I agree, David. I mean, I think that's the challenge is we couldn't, because schooling was so high and there was no difference, we can't look at that mechanism. So I do think, the mechanism then has to be either, the cash on its own provided to the girl working through some other route, right? Whether did it improve mental health? Did it maybe change partner dynamics? But it's not a schooling mechanism. So it's true in this study, we can't look at that. And remember that the measures of risk behaviors were self-reported and subject to reporting bias. Exactly. And this could have been differential by arm. So that's something that I think everybody says is, with self-reported behaviors, difficult to, there could be reporting bias. I think ACASI helps. I think as opposed to perhaps interventions that are more, so all the young women got was the cash, and both arms, they came annually, they did a survey, and they got pre and post-test HIV counseling. So there was no messaging with the cash. There was no additional really support with the cash, unless somebody was having a problem with getting the money. There was no, we didn't see them monthly. The money just went into the account and they got a text to say the money's in your account. So I think there's less of that risk of when you're doing a behavioral intervention and you kind of feel the pressure to report the right thing. That said, maybe they still felt pressure to report the right thing because, they knew they were getting the cash. And I think that's just something that is sort of unavoidable. And then I think, David's last thing, there's a bunch of, if doing the trial again, apart from choosing a different site, would you do a cluster randomized trial? Yes. And it's funny because James doesn't remember this, but I remember James and I having long debates about cluster versus individual. And, that was coming off the wake of a number of cluster randomized trials that just had not had the power. I think showing effects in cluster randomized trials is really hard. And, but we really thought that the mechanism of effect was an individual level effect, that these were household level structural barriers to schooling, that, if you can't afford to go to school, it doesn't matter if your friends are going, and it doesn't matter that the potential for peer effects and other spillovers to us seemed really not possible. And yet, that's what we saw then that it seems like that is going on, and that I think we are in this not weird, but in this position where there's high social protection. So, the fact that there weren't huge financial barriers because a lot of people had the social protection programs in place, and then this nudge from peers in the study then sort of was enough to push people to school. if we had known that, we probably would have gone back and done a cluster randomized trial. And actually, when talking to the bank about their new trial, I'm like, you are doing a cluster trial, right? And they were like, yes. I'm like, okay, good. There's a question about, would you expect that the intervention impact would be different in an urban inner city compared to Agincourt, which is rural? Potentially, yeah. I mean, I think, most people have done these trials in rural areas. I know Sinead and folks at WRHI did a pilot in inner city in Hillbrow in Johannesburg and saw some interesting effects that show, I think, and Sinead, you can comment, but certainly feasibility and acceptability of doing it in an urban environment. But I think that it raises different challenges, right? And I think you just have to think about context again, and potentially that you're competing with more things going on in an urban environment, and maybe SES, again, is higher in an urban environment. So from a cash transfer perspective, thinking about, our school fees and transport costs and other things higher. If you're looking at a conditional and if you're looking at an unconditional, again, what's your mechanism? And I certainly think that, again, any context with these interventions, you need to think hard about what you're doing and how you need to address the risk. Know your epidemic, right? As you have said for a long time. I think it's so true. There's another question, a few questions on the 4-week pilot. Oh, so this is what was called a booster intervention that we did, which was the 4-session intervention. This was just a sort of feasibility, acceptability pilot we did, and it was 4 sessions. They were done weekly, and they were spread out over a month. It was a group of about 10 to 12 young women who were together with a facilitator. And I think we're going to change the model. Basically, I think it was too long, but what we did was a morning session with the girls that was sort of participatory learning, but group classroom based, and most of the sessions were drawn from the Pop Council's Adolescent Girls Empowerment Program, and also from Sanke Gender Justice's works. But we also looked at stepping stones, and we looked at the sisters curriculum from Image. So, a lot of those programs have very similar activities and curricula. So we did that. And then in the afternoon, there was a field trip. So, for example, the session that was on SRH and HIV skills, we then went to the clinic, and they actually got to tour the clinic and meet with the sister. And that was actually incredibly popular. And actually in qualitative interviews we did, the girls talked a lot about, it was the first time they'd been to some of these places, and a number of them wanted to go back. So that, I think, was sort of an innovative, interesting thing. So, yeah, and I'd be happy to share more information on it with the Deirdre. I'm happy we're writing it up for the council. We're thinking more, though, again, given the feedback we got about spreading it out over more sessions that are shorter, because we certainly had a lot of young women who weren't able to do it because they were not available time-wise. So that's something we're thinking about.
Just on that piece, because it reminded me as well of the Image trial, which was also done in that area, and also sort of focused on cash, but included an empowerment piece. And it looked like the booster sessions had also started to sort of adopt that kind of approach of cash plus. I'm just curious what outcomes you measured sort of following the booster, and sort of what sort of the idea was in terms of sort of short or longer term outcomes from that piece.
Yeah, so, the idea originally, the council had some funding mechanisms to look at kind of adolescent girls and programming kind of questions, and this one idea was, could you sustain effects? And so it was supposed to be a booster. Obviously, we'll see. So this was done. They did it. So we're trying to bring back the cohort to look at what's going on post-intervention, and so girls who exited in 2012 and 2013 from the trial because they were meant to finish high school, we brought back this year. And at that time kind of did another survey and tested for HIV. So that's our baseline for the booster. They then got the intervention, and now we're currently going back and doing another survey so we have control girls, we have cash transfer girls who didn't get the booster, and we have cash transfer girls who got the booster. And we're really we wanted to see who came to the sessions, how many sessions, so some of those logistics that I was talking about, and then things that we really thought could actually change in a short period of time. So things like, did they go to the clinic? Did they go for testing with a partner? Have they been for HIV testing? Have they gone for a job interview? Did they go back to this we took them to a youth center, a sort of youth development center that helps kids with job training and things. So we have a bunch of questions that are related to looking for jobs and kind of getting skills. And then another session was focused on gender-based violence. So we asked some questions about, do they feel more knowledgeable about where to go for help if they or a friend is experiencing it? Have they been to any of these centers that offer services for people who've experienced gender-based violence. So very kind of service kind of uptake outcomes. I mean, we're measuring all the other stuff, but all the behavioral and not biomarkers, but the other things like, number of partners, unprotected sex, transactional sex. But I don't anticipate seeing those kind of changes in a short period of time, but we have them. And I guess, what's the next step is, so the idea would be if this was feasible and tractable, we would like to be able to sort of roll it out. And I think the question would be, is it more for I think we're thinking more about the 18 to 24s, how cash fits into it at this point. I'm not 100% certain. I think there's still debates about the unconditional versus, if you're doing unconditional in this setting, how much and what should it look like versus tying it to something like, going to the clinic and getting a prevention package. And I think there's still, obviously we need to try different models, and I'm not totally clear on that at this moment.
Thanks. I'm looking at the chat, and there seem to be a few questions about sort of transactional sex, the definitions of transactional sex, and perhaps sort of what could we have expected if given the sort of definitions of transactional sex. So I don't know whether you want to talk a little bit about sort of transactional sex and what that might mean potentially for targeting sort of at-risk groups. I think you sort of talked about that a bit earlier.
I think it's challenging, right? Obviously, quantitatively measuring transactional sex is difficult. We used a series of questions that first went from asking about, so we asked it in a partner grid for the three most recent partners, and within the context of the partner, we asked, has this partner ever provided you cash, just generically? And then there were some series of, what was the cash for? And then so there were like 4 questions. And then the last one was, do you feel like you have to have sex with this partner because they're providing you cash? And that was the transactional sex. We also asked them the same 4 questions, not for cash, but for other things like, goods, clothes, transport status, sort of. So we had another series of questions that, does the partner provide these things to you? And then, what do they provide? How often? Sort of what amount? And then do you ever feel that you have to have sex with them because of that? I don't think that's ideal. I think transactional sex is a continuum, and I think that's probably at the far end maybe of a continuum, because maybe they're girls that we would say are engaging in transactional sex but don't feel like they have to have sex with the partner because he's providing these things, but maybe have reduced. I mean, for me, it's always like, at what point does the transaction in a relationship, and I think all relationships are transactional in nature, so at what point does that cross over to putting you at risk? And I think that's really hard quantitatively. But nonetheless, that's how we asked it. And I will say that 80% of the girls report getting, material support from their partners. But then only about, at baseline, only about 14%, and here you see 10% in this study reported that yes to that question, I feel like I have to have sex with this person because of that. And actually Meghna and I, because she worked on this, the qualitative part, have added to this revisit a number of other questions to try and get more at consumerism and to get at real reasons for the motivations for originally getting into the partnership. Was one of the top reasons they got into the relationship and then stayed in the relationship based on kind of the material goods, or is it something else? So we're trying to sort of unpack things a little bit more with some of our newer data collection rounds. For targeting, I think it's hard, especially in younger age groups. I feel like we've talked about, I don't know if Sinead, you and I have talked about this, but this thing of I think this question is is transactional sex a continuum with sex work at one end as well? And are some of these young women engaging in sex work, but they wouldn't call it that because they're just not there, and maybe in 10 years or 5 years, they might consider themselves sex workers, or maybe they won't ever. And we do know from some other work in this area that certainly we see young women in bars, or who report going to shebeens and bars and not drinking, but going to these places. They had at baseline a much higher risk of HSV2, certainly, and if they did both, if they were drinking and at these bars, then they were at increased risk, and that was associated with transactional sex as well. I'll say from the incidence data, we also see that transactional sex in older partners are highly, highly correlated, which we didn't see at baseline in Meghna's work. So I don't know. I don't know if that means doing venue-based targeting, that seems like an obvious thing to do, but I think it would be harder to find girls who might be doing this occasionally or just if it is so normative, I think thinking about targeting is hard. And then I don't know, rather than in like if we're doing like PrEP trials or other trials and we're asking about these questions in a screening way, that's certainly maybe a way to identify people at higher risk in the younger ages. But I don't know in a more generic setting where you're delivering services. I think it could be quite hard. So I'd be curious if people have thoughts on that. But
thanks very much, Audrey. We've come to the top of the hour, but this has been a really great session, and you've definitely, I think, sort of given us a real understanding of the results as well as the kind of implications of the results, both for, I think for the South African context, but also more broadly, and sort of what this means for future work. So thanks very much to you for taking the time to do this webinar. We're very appreciative. Thanks very much, Audrey, and thanks very much to everyone who participated.